Dr. Nagaraj Desai sir to take over for the further proceedings with the scientific session.
Hi, friends. Indeed, it is wonderful to have so many stalwarts on the platform today. Having had a great introduction by my teacher and mentor, Professor P. S. Shankar, it will be interesting to listen to Dr. Manoria, who happened to be my senior in PGI Chandigarh as I was training for cardiology. That was nearly 45 years ago. Indeed, the the history of hypertension also is not that old in terms of the total perspectives and understanding of hypertension management. I'm sure the ancients that we have in the audience would have already appreciated just about 50 years ago when BMJ published its article on hypertension, how it was neglected, saying that somebody said that it is dangerous to treat high blood pressure. From that status, we have carried on and start talking of lowering the blood pressure, better it is for our health. It is interesting to listen to the experts like Dr. Manoria, who has extensive experience in various international fora and also has been authoring several publications on cardiology and cardiovascular medicine, and understand his perspective as to what are the newer facets of hypertension that we as clinicians should be aware of. Professor Manoria is a great communicator, and I will not be standing in between him and you guys. And please, I request Dr. Manoria to start his presentation. Thank you so much, Dr. Biradar, and I'm looking forward to listening to many experts on this occasion. Dr. Manoria, please.
So thank you, Dr. Nagaraj Desai. It's indeed a great pleasure, and I'm delighted to participate in this program organized by the Karnataka API ICP Chapter. So for the next 15 minutes, I'll be talking on hypertension new facets, looking behind the number game. All of us know the numbers of blood pressure are very important and crucial in hypertension. And World Hypertension Day 23 has rightly emphasized on accurate measurement of blood pressure, its control for living longer. And the guidelines cover the number game with great precision and perfection in terms of diagnosis, initiation of treatment, and targets for BP control. But I'm not going to bore with these numbers of blood pressure because you have heard it so many times. But behind the number game, there are a panoply of facets which are important and are of great interest to a clinician. So the first issue I'm going to discuss is all of us realize that the mortality in a controlled hypertensive is 2 times compared to a normotensive, which means you're a hypertensive patient, your blood pressure is controlled, still you do not become equivalent to a normotensive person. So let's see what are the reasons for this. The first and the most important reason is that atherosclerosis continues unabated even in a controlled hypertension, which means even if your blood pressure is normal, you are not immune from acute myocardial infarction, you are not immune from a stroke. Antihypertensive agents, they decrease blood pressure related complication, which means they will decrease left ventricle failure, they will decrease stroke, dissection, and so on, but they do not provide atheroprotection. And this was very, very elegantly shown by the HOPE-T trial, which was carried out in intermediate risk patients. CV went 1% per year, and you can see when hypertensive patients were treated with blood pressure medications only, Kentisartan 16 plus HCTs in this, you can see there was no significant change in the primary endpoint of cardiovascular death, MI or stroke. But when the same patient was given only 10 milligram rosuvastatin, there was a statistically significant reduction of 24% in the primary endpoint of cardiovascular death, MI, and stroke. And if you remember Ascot LLA, 10 milligram of Torva in hypertensive patient, total cholesterol less than 250 after 3 years, decreased non-fatal MI and fatal MI by 36%, significant. The other reason which is now being increasingly recognized is that fibrosis occurs in different part of the cardiovascular system, and this is a new illustration from a review article from a hypertensive. Pointed. You can see that hypertensive heart disease is no longer considered as a left ventricular hypertrophy. There are several new facets were added to atrial myopathy, fibrosis in the major arteries, fibrosis in the smaller arteries, and fibrosis is now very easily recognized by LGE-CMR, that is late gadolinium enhancement. Fibrosis occurs in the myocardium. You can see these white spots. And once fibrosis occurs in the myocardium, this ventricle becomes more prone for development of heart failure. It becomes more prone for development of ventricular arrhythmias and even sudden cardiac death. All of us know scarring in ventricle always predisposes to cardiac arrhythmia, particularly ventricular arrhythmias, whether you are talk of a hypertrophic cardiomyopathy or an arrhythmogenic right ventricular dysplasia or so on. So scarring and fibrosis of the ventricle adversely alters the prognosis of hypertensive patient, and now we can easily pick up by LG-CMR. Fibrosis also occurs in the atria and produces atrial myopathy, and you can see the different grades of LA fibrosis on LGE-CMR. And if you have a significant atrial fibrosis, this predisposes to development of atrial fibrillation and stroke. And an intelligent interventional cardiologist who performs radio frequency ablation of atrial arrhythmia always looks on the atrial fibrosis. If an individual of atrial fibrillation has advanced fibrosis like this, the probability of sustaining atrial sinus rhythm is very remote, and the procedure is not likely to produce beneficial results. Fibrosis also occurs in the aorta, and if we recollect the normal compliant aorta or the big arteries, what do we have? The normal pulse velocity is 8 meters per second, and when in a normal individual, when the impulse travels from the aorta during systole, it goes to the periphery, comes back slowly and slowly, slowly and slowly. By the time it reaches the heart, diastole is already set in. This increases the diastolic pressure and increases the coronary filling. On the other hand, if you have developed aortopathy in hypertensive heart disease because of fibrosis, the aorta becomes less compliant. This results in increased pulse wave velocity, maybe to the tune of 12 meters per second. And what will happen? When the impulse traverses from the aorta to the periphery, it comes back very fast, and when it comes back, systole is already ongoing, and this produces a panoply of adverse effects on the cardiovascular system. It increases the central aortic pressure, increases the LV afterload, the patient may develop left ventricle failure, increases the pulsatile strain, and increase the chances of plaque rupture. There is no diastolic augmentation, no increased coronary filling as happens in a normal individual. The issue is there any solution to minimize fibrosis? We do not have any proven agent or any large RCT, but very interesting data emerged from the long-term follow of the LR trial, as you can see in this slide, 2016. Significant reduction in the conduction system disease with lisinopril compared to CTD or amlodipine after 5 years follow-up, despite the fact that the blood pressures were higher in lisinopril group, and this seems to be due to antifibrotic property of RAS inhibition, and this could play a role, and certainly this will require an additional trial in future to assess the antifibrotic actions of the RAS inhibitors in hypertensive patients. And therefore, it stands to reason that when we are treating hypertension, we should not only be treating the 24-hour blood pressure, the nocturnal blood pressure, the morning surges, the blood pressure variability. We should also focus on vascular remodeling, because this remodeling of the larger arteries produces strokes like ischemic stroke. Smaller artery remodeling produces lacular infarcts and cognitive decline. The second issue, which is again very, very important, is target heterogeneity in hypertension, which means do all target organs respond in similar fashion to lower blood pressure, which means you have a hypertensive patient, you lower blood pressure, will all target organs, which means the heart, the brain, the kidney, respond in a similar fashion? So let's first look in the brain. The dicta for brain is lower is better. Lower systolic blood pressure is better, lower diastolic blood pressure. And how do we know it? This is data from the famous Accord trial, which compared 140 systolic blood pressure to 120. The trial was negative, but still you can see there's a reduction in the stroke, which was significant. And the inverse trial shows as blood pressure is lowered, there is additional decrease in the stroke. So when we talk of brain, tighter BP control is important if you are not suffering from disease in the cardiovascular system of the heart. Lower is better, and this applies to brain. But when we come to the heart, the story is not the same. Lower diastolic blood pressure is bad for the heart because coronary artery filling occurs in diastole. And this is the subgroup analysis from the famous HOT study, and this shows the MI per 1,000 patients years. When blood pressure, diastolic blood pressure is lower, you can see these are MI. MI are always larger in patients with lower diastolic blood pressure. Not only this, the INVEST trial also very clearly shows as you lower blood pressure, there is a decrease in MI, but if you lower blood pressure further, say less than 80, there's increase in MI. So lower diastolic pressure, particularly the patient is suffering from coronary artery disease, you have to be cautious. If he's not suffering from coronary artery disease, it may not matter. And therefore there seems to be a J curve for the heart in the context of diastolic blood pressure, and this seems to start when you lower diastolic blood pressure below 70. And very interesting paper appeared in JACC 2016, which tried to assess the relationship between low diastolic pressure and the elevated high sensitivity troponin levels. You can see when we compare a diastolic blood pressure of 80 to 89, diastolic blood pressure 60, more than double the odds ratio of high sensitivity cardiac troponin T, equating exceeding the normal value, and this also increased the coronary event, which means if you lower diastolic blood pressure to 60 or low, the cardiac troponin levels are also increased. And this is another interesting study which shows that those patients of coronary artery disease who are revascularized, they tolerate lower diastolic pressure much better. The third issue I'm going to discuss is of increased sympathetic activity, which is now being increasingly recognized. Several publications have appeared. This is in Indian data, and you can see the prevalence of sympathetic activity is 62.42% data from India. And this is another beat survey, which is again from our own country. And what does it say? An increase in heart rate by 10 beats per minute is associated with 14% increase in CV mortality, 20% increase in the total mortality, and resting heart rate is elevated in Indian hypertensive. It correlates both with systolic and diastolic blood pressure, and sustained elevation of heart rate is an independent risk factor for adverse clinical outcomes and could be a therapeutic target. And all of us are aware of the Indian heart study. Dr. Kaul is not there, who carried out his study. Otherwise, I would like to have his expert opinion, which clearly shows that in Indian, the average resting heart was elevated around 80 beats per minute, both in the office BP measurement and in the home BP measurement in both the sexes. Now, this is again a very interesting data from the value trial. Whether blood pressure is controlled or not controlled, if you have increase in the heart rate, there is increase in the cardiovascular events. And there are several such data from several trials. If you look at the life study, all cause CV mortality in relation to changing heart rate, the higher is the heart rate, more is the all cause mortality. And look at the INVEST trial. If your heart rate is increasing, you are increasing the composite of all-cause death, non-fatal MI, and non-fatal stroke. And sister study whether you are men, whether you are women. If the heart rate increases, you can see there's a progressive increase in the all-cause mortality. Sympathetic system, all of us know, adversely affects the cardiovascular system, not only hypertension and several other factors I'm not going to detail. And sympathetic inhibition is a goal of antihypertensive therapy, we know, and produces beneficial effect in diverse ways. But the big answered question is that can we offer beta blockers in controlled hypertensive with increased resting heart rate even in the absence of CAD-HF arrhythmia despite lack of recommendation by guidelines? We do not have any randomized controlled trial, but the data seems that this is likely to benefit. The fourth issue which we come across these days, all of us know isolated systolic hypertension internally. All of us are familiar with this problem. But now what is being increasingly seen is that we are seeing isolated systolic hypertension in young, particularly those who are in the IT workers and those who have a lot of stress. The systolic blood pressure is elevated and they poorly respond to other drugs. When beta blockers is given, the response is very good. And publications are again emerging in the literature. This is publication 2016. Isolated systolic hypertension in young, old, everybody knows, people is not spurious and should be treated. So this is another facet which is cognitive decline somehow is not paid so much attention in the treatment of hypertension. The earlier you start treatment, less will be the cognitive decline. This should be one of another important reason why treatment should be started early. And look at this cardiac study which took a 25 years follow-up from CAD risk cardiac patients, which recruited healthy young individuals aged between 80 to 30 years and followed up mean age 25 years for next 25 years, and this showed increased cognitive impairment in middle life. The mean age was around about 50. So again, cognitive decline is a very serious complication of hypertension. Once it occurs, it cannot be reversed, and therefore this is another very strong reason hypertension should be treated early, and blood pressure variability should also be targeted. The other issue is vascular aging, and all of us know hypertension is a very important cause of premature vascular aging. There are other factors also, no doubt, and therefore these days we can have non-invasively measurement of our vascular age based on the systolic, diastolic blood pressure, the pulse pressure, the augmentation index, and pulse wave velocity, and the central blood pressure. The computer calculates. So look at this individual. Chronological age is 54 and his vascular age is 57, reasonable. Look at this individual which I have shown, this is the one. The second individual, chronological age is 37 but his vascular age is 46, bad. Look at the third individual, chronological age is 54 and vascular age is 73, very bad. So hypertension is certainly an important factor for determining the vascular age. The other issue which we commonly see in the Indian context is that there's clustering of risk factors in hypertension. Therefore, while treating hypertension, we must also focus on the other concomitant risk factors which are commonly associated, particularly diabetes, dyslipidemia, smoking, and so on. And here you can see large number of hypertensive patients have more than one risk factors. And therefore, what we do to our patient is we provide this mobile number, health mobile number. And this number is 13080100070. What does it stand for? 13080, which means you maintain your blood pressure at 130/80, 100 LDL, less than 100. So you target dyslipidemia these days, preferably less than 70, because atherosclerosis stops at 70. 7 is for HbA1c. Try to maintain your HbA1c around about 7, and smoking is 0. So this is the mobile number we give to our patients to target the concomitant risk factors which often cluster in hypertensive patients. And the next very important issue is the quality of life. All of us know the treatment of hypertension is a long drawn out process over the years, and therefore special emphasis should be laid on quality of life. We should never forget life is not merely being alive but being well, and our hypertensive patient should not only live but also feel well. And while selecting drugs for treatment of hypertension in a young patient, one must be very, very cautious that it does not interfere with their sexual life. But the problem currently, particularly with the young generation, is digital intoxication has become rampant and is emerging as a big barrier for healthy life and prevention of non-communicable diseases. The young generations are busy with smartphones, WhatsApp, Google, LinkedIn, Facebook, Instagram, Twitter, Snapchat, Tinder, and so on. So what is suggested is that these individuals should undergo digital detoxification by doing a fast, not the conventional fast, without social media at least twice a month, preferably every week. The ninth issue is our dismal control rates with hypertension. As Dr. Mugunathan pointed, 10 to 12% of whatever is the figure. And the reason for this is if you want to increase the prevalence of controlled hypertensive, you have to adopt a cohesive efforts, as you can see. All potential stakeholders in hypertension must come together, achieve cohesive efforts, non-government organizations, government organizations, healthcare professionals, scientific organizations, electronic print media, social workers, but this is not seen in our country, and that's why the control rates are dismal, 10 to 12%, which is indeed very distressing, and there's an urgent necessity to increase the blood pressure control in our country. And the last issue which I'm going to discuss is hypertension-free India. We have very effective antihypertensive agents for control of blood pressure. No doubt it decreases morbidity and mortality, but this does not decrease the total number of hypertensive patients. Therefore, aim should be to stop hypertension and build an hypertension-free India. This is a very, very difficult task, but indeed possible. Let's see. And this can be achieved by primordial prevention. Primordial prevention means prevention of emergence of risk factors in population in which they have not yet appeared by individuals in mass health education, and the most effective targets are the nursery kids. It is seen that if they are taught lifestyle modification, they continue to follow it in their later years of life, and the incidence of NCD is significantly decreased. Data from the familiar trial, data from the Wellston Futser trial from Spain, and therefore this would take several decades, but I think this should come into vogue so that we also decrease the number of hypertensive patients. Thank you very much for your kind attention.
Thank you, Dr. Manoria, for that wonderful presentation. In fact, you made my life so easy to bring out almost quite a few, several facets of hypertension that we would like to discuss with our patients and with the families of the patients. And I personally would add on yet another facet of managing hypertension, managing the family also. In fact, if you influence the families, you will be able to influence the patient as much because the spouse will control many a time a patient with hypertension. In a very lighter vein, I'm sure all the participants will appreciate that as much. Now, let's try and understand from the point of view of the listeners if there are any kind of missing points as he was presenting his illustrious slides from his slide deck. Would you like to kind of re-emphasize a couple of points that you mentioned about the diastolic blood pressure and the J-curve hypothesis, for instance? Would you like to kind of little dilate upon, will it be same if a patient has a heart failure, or will it be different if the patient doesn't have a heart failure? Because, if you talk to some experts in heart failure area, they say that, look, blood pressure is important, but not that important. Try and achieve as much dose as possible. Make sure that the blood pressure, even if it is 90 by 60, continue to manage the blood pressure and push your luck to try and increase the drugs for heart failure. Before you could get in, may I request all the participants to pose their questions to the speaker here so that I can try and pass it on to him in case he is able to kind of take a look at the chat box. Otherwise, I can help him out. Now, as he's preparing for his answer to my question, hypertensive heart failure, for instance, how does he feel about this particular aspect he did not touch upon? Could you dilate upon it,
Yeah.
Dr.?
Heart failure will never tolerate higher blood pressure because it adversely affects heart failure. If the patient has no coronary artery disease, lower blood pressure is going to be beneficial, is not going to harm. But you have a significant coronary artery disease which has not been treated, this may adversely affect coronary artery disease. Patients of aortic regurgitation all of snow diastolic blood pressure is zero or slightly elevated do not have any problems because the coronaries are normal. So all depends on whether you have a coronary artery disease, a significant coronary artery disease. If you don't have significant coronary artery disease, diastolic blood pressure is not going to matter, even if it is low.
Yes. Now, yet another important point, as you were talking about, in fact, each of your, issue that you presented to us today calls for a detailed discussion by themselves. In fact, going from one point to the other point, unless Dr. Towle and has some points to say. If he is able to join, Dr. Sangram, you are able to find out whether he's able
Yeah,
to.
no, sir, still he has not yet joined.
Okay.
We are waiting for him. So, meantime, can we have a comment from Dr. Maya and Dr. Jayant Andani, sir, as well?
I was trying to kind of get to that, in fact, because I wanted to give them a little food for thought to ask questions. In fact, may I open this presentation from the individual comments, the experts on the field, on the platform here, please. Dr. Maya to begin with, and followed by others also who are there on this platform. Dr. Antani, Dr. Yashankar, Dr. Murugadas. Thank you.
Dr. Maya, sir, can you unmute and speak? Any comments from your side?
As he's getting ready, in case Dr. Manoria is able to see this question, please elaborate how to treat an elderly with lower diastolic blood pressure and a higher systolic blood pressure in a patient with CAD. Dr. Manoria, please, what is your take on this?
See, if the patient does not have a CAD, there are no issues.
Yes.
But if the patient has CAD, best thing would be to treat his CAD by revascularization, then there will be no problems. Otherwise, you lower diastolic because when you lower systolic, diastolic also gets lowered.
That's right.
So, best would be to revascularize the patient if he has a significant coronary artery disease and treat his hypertension. If
Yeah.
that is not possible or feasible, then you have to slowly decrease the blood pressure with a close look at the coronary artery manifestations.
One question that I wanted to ask you, would you like to select a drug for this particular patient to control the blood pressure? Elderly gentleman, systolic
See,
blood pressure.
elderly, we usually use calcium channel blockers because of the elderly arteries which gets less elastic tissue. If not controlled, you can add a diuretic. The first and second choice usually falls on, say, amlodipine, which is long acting, or maybe the new calcium channel blockers, and the diuretic may be CTD. So that is usually the first choice.
And you do not want to go for beta blockers, right?
Elderly beta blockers are not effective. They are usually effective in young, where sympathetic stimulation plays a very important role. In elderly, it is RAS stimulation and the elastic decreased elasticity and the vascular remodeling, which plays a major role. So
Fair.
beta blockers, unless they have a concomitant cardiac condition like heart failure, arrhythmia, or so on, otherwise beta blockers are usually less effective.
Thanks, Dr. Reshma, for asking this question. May I request Dr. Maya to get on with his comments and criticisms on this particular presentation? If he is not ready, Dr. Murugadas.
Dr. Muruganathan also is not there, sir. He has left.
Muruganathan is also not there. Okay. How about Dr. Shankar? Sir, kindly.
He is also not there. Dr. Maya, sir, you want to tell?
Can I interject?
Antani is there. Sir,
Yeah.
please.
Hello.
Elderly
So
patients we see quite a
I have a
lot
suggestion.
who
I
have
have a
higher
suggestion.
diastolic pressure, 50, 60 like that. What should we do?
No, can you repeat the question, Dr. Nagraj?
The diastolic pressure comes to around about 50 with or without treatment. Systolic is a, as you know, as you get older, systolic pressure increases,
Dr.
So,
Nagraj, can you repeat the
diastolic
question?
comes down.
yeah. In fact, he's asking almost the same question that we already addressed. In case the patient blood pressure is 50 or 55, and their systolic is higher, what should we do? Should we kind of would you like to comment on the so-called pseudo hypertension of old age at this stage?
Yes, pseudo hypertension. Usually, we do the Osler's phenomena to find out is really hypertensive or pseudo because the vessels get more
As we all
clogged after
know, we are
compress.
constantly reducing the systolic pressure. We do not do anything but the diastolic pressure. But are we worried?
Yeah.
Diastolic pressure, we only worry if you have a symptomatic coronary artery disease or significant coronary artery. Then otherwise you lower diastolic pressure to 50, 40, nothing happens. Control your systolic pressure, that is the first aim. Don't bother about the diastolic pressure.
Because my patients come and ask
Yes. Yeah.
me, sir, diastolic pressure is so low. Is it okay?
Yes. You should reassure them.
No problem.
We are trying to. Yeah, there is actually Dr. Antani wanted to talk about something.
Yeah,
Dr. Antani, please.
I have a suggestion that though we all know the morning surges of blood pressure, and we know all about circadian rhythm of blood pressure, and still most of the family physicians and physicians do not measure early morning blood pressure. Between 5 a.m. and 8 a.m., blood pressure is always high. And later on in the day, afternoon and evenings when practice occurs, practice is being taken, seen the patients, they're on the lower side. How do you account for that?
Fair enough. I think it is an education that is required. Dr. Manoria, you have any
Yes.
point to add?
See, when we are controlling blood pressure, we look at the nocturnal pressure, the dipping pattern. We look at the blood pressure variability. We look at the morning surges. Morning surges means if your blood pressure rises more than 35, and the normal dipping is 10 millimeters of mercury. So control of blood pressure is not assessed by a single reading. At least you can have an ambulatory blood pressure monitoring once so that you can have an idea of what is happening to the patient. Is he having morning surges? Is he having BP variability? Is he having nocturnal dipping, no dipping, or increased dipping? So you can have an idea first, and then the aim is to have a total 24 hours blood pressure reduction.
How do you want to kind of propose to a patient in your practice about the morning surge of blood pressure, Dr. Manoria?
See, for morning surges of blood pressure, they are important because they are associated with increased cardiovascular events, strokes, and even myocardial infarction.
How do you
So,
want to
if you are on a long acting drug, the recent trials have shown it does not matter what time you take the blood pressure. If you are a short acting drug, you have to take it in the evening because the effect weans off. But the recent trial showed that the long acting, 24 hours acting, they don't matter much. But morning surges are certainly very important, and we see MI getting admitted early, strokes getting admitted early in morning. Morning surges, and the definition is more than 35 millimeters rise.
Fair enough. Now, I want to find out from you, in your practice, what do you advise your patient? Do you advise a home blood pressure monitoring, or would you advise the patient to come into the doctor's office, or would you like to advise one of the family members to measure the blood pressure and keep a record of it and to be reviewed by you? How exactly you practice this part of hypertensionology?
See, first visit is usually in office blood pressure,
Sure.
but all of us knows that blood pressure represents blood pressure at that particular moment. You should ask the patient for a home blood pressure reading also, and if possible, you should have at least once an ambulatory blood pressure also. And you can take average of the home blood pressure monitoring. The problem with home blood pressure is that you do not know what is happening in the night, what is happening in the early morning. So if possible and feasible, because now most of the pharma supplies ambulatory blood pressure and it can be done free of cost. So cost should not come in this way, and we do, even if the patient is not affording, we, for example, some pharma, they provide ambulatory free of cost. So once in a while, we always have an ambulatory blood pressure monitoring and see what is the pattern, because pattern is different in different individuals. Home blood pressure monitoring is very good, but does not give a total picture of the hypertension, what is happening round the clock, because you cannot measure blood
Sure.
pressure in the night and early mornings.
The data that
But
can
the
be
decision has to take on looking into factor all the office blood pressure, the home blood pressure if possible, and ambulatory blood pressure.
The
how about
second,
the unobserved blood pressure that was measured in the sprint trial at this stage? Would you like to comment on that?
See, the way blood pressure was measured in the sprint trial is not possible in our day-to-day practice, and therefore, what is measured as 120 in reality may be 130 or little higher. So 120 was having less cardiovascular events, which would mean in that the blood pressure which is measured in the usual way would be 130 or so, and that is corresponds to the common target of 130 by 80, because the way the blood pressure is measured, so
that is
much time,
unequivocal
silent room, three
statement.
reading, nobody, and it's very difficult in, at least in the Indian, where the number of hypertension patients are huge, everybody is busy in this practice. Countries where the population are not so sick or number of patients are less, you can try, but there is a distinct disparity on how you measure in the sprint trial and the
Right.
conventional measures.
Yeah, having said
The second problem, Dr. Nagraj Desai, Dr. Manoria,
Yes.
which I face is the orthostatic hypotension in diabetics in the elderly. There's a very big problem. We try to aggressively treat the blood pressure, and we have, in fact, including recently my brother also, they fall down at often odd times. And only ABPM helped me to make out that he was falling in the afternoon with a blood pressure of 80 systolic. And the
yes,
rest of the time, his blood pressure was around 130, 140, 150.
how do you like to handle this particular aspect, Dr. Manoria?
See,
What,
first you should try to avoid drugs which produce significant postural fall. And now we have these drugs which minimize postural fall. Previously, we used to use fluoricod, but now we have the newer drugs which decrease postural fall, and they are quite useful.
Fair enough. Now, I wanted to ask you here, in case you are giving 4 drugs for a patient with hypertension, which may not be unusual, of the 4 drugs, if you have, which one would you like to withdraw in case the patient happens to have some kind of a postural symptoms and you record a blood pressure which is lower on standing?
See, first
What is
I
your,
like to
what is
withdraw
your
the first I like to withdraw the diuretics,
first important statement? I'm glad that you made that.
and second maybe a RAS blocker, telmisartan, if you use on a telmisartan,
Mhm.
because calcium channel blockers will not produce so much postural hypertension.
Fair
But
enough.
diuretics certainly, and particularly in the summer season in the Indian context, you can have postural falls. Or if you have developed fever or gastroenteritis, again the same problem comes.
Fair enough. I mean, may I, on behalf of you, can I say that if the patient is on multiple drugs, especially if a diuretic is on,
Yeah.
it always make it a point to measure the postural blood pressure
Yes.
so that
Yes.
you will not be taken by surprise when the patient has difficulties there. I hope Dr. Anthony's point has been well
See,
addressed by us.
the second point is right arm and left arm measurement of blood pressure has been advocated frequently, and
Yeah.
particularly for aortopathy or coronary artery disease, or it is most of the time not done.
Yeah.
Is it essential that this should be recommended?
What do you think, Dr. Manoria, at this stage
If
about
there is a suspicion of an aortoarteritis or a atypical coag, certainly you should measure. Otherwise, normally the difference is less than 10, and every time we don't measure in right and left arm. But if there's suspicion of a presubclavian coag or an aortoarteritis while examining, we feel certainly we like to measure in the left and right. Or if somebody is already measured, if it is more than 10, we like to investigate as to what is happening in the arteries of the upper limbs. And they'll also like to measure the lower limb blood pressure also once that is
Can,
done.
can I say on your behalf again, also, yeah, additional point, whenever you initially work up a patient for hypertension, have all the blood, have all the measurements of all the 4 limbs so that you are clearly understanding and you're not missing any kind of aortopathy and arteriopathy. And also, you know which arm you like to measure. Indeed, quite a few manufacturers of instruments, they tend to recommend the left side so that the self-monitoring becomes easier for the right-handed individual rather than right-hand blood pressure. And that could be one of the reasons why the left-hand, right-hand confusion can be perceived by the patients. You have another question here. What measures to be taken to address the cognitive dysfunction in hypertensive patients? What is your suggestion here? Do you want
Cognitive dysfunction is preventable, there's no treatment for it. If you treat blood pressure in early stages, maintain a good control, cognitive function is likely to be postponed. If once cognitive function occurs, it cannot be treated, there's no treatment for it. Make sure there's no other cause of cognitive function due to some other concomitant disease.
Fair enough. Now, do you like to think that adding statin upfront to a given patient of hypertension, you are going to decrease cognitive functions or increase cognitive dysfunction? Because statins are also supposed to cause sometimes difficulties there. What do you
Adding
think?
what? I could not get.
Statin induced
Oh,
serotonin.
see, I showed you in the Hope 3 trial, if you are a hypertensive agent and if you are more than 45 or 50, statin should be taken. Very clearly showed Hope 2 trial, 1% per year was the event rate, and you treat hypertension, nothing happens to stroke, cardiovascular death, and MI. You had 10 milligram atorvastatin, 24% reduction. Atherosclerosis is an inevitable process, and because statins hardly have any side effects, I think adding statins will produce more benefits rather than doubt of getting a toxicity.
Well, now I wanted to ask you clearly, stroke is different from cognitive dysfunction or cognitive decline.
Yes.
Cognitive decline, having been shown in the sprint trial, reducing the cognitive decline. And also, in addition to that, do you have any suggestions for this particular individual who wants to prevent cognitive decline, or just that high blood pressure control is good enough?
I am not aware of any drugs which decrease cognitive decline.
That's
Control
right.
of blood pressure is the only thing. Sometimes there will be concomitant disease which now can be easily diagnosed by the current imaging techniques.
Yes.
Alzheimer's and that disease which produces, and multiple stroke dementia is also known to produce cognitive decline.
Yes. I wanted to ask from my side, you were mentioning about the subclinical atherosclerosis and atherosprotection provided by the antihypertensive agent is rather dismal. Considering that, to what extent you would like to investigate a patient of hypertension for evaluating for the presence of subclinical atherosclerosis in your practice?
Personally, I feel because the data on atherosclerosis and lipid is so strong, if you want to arrest the progression of atherosclerosis, decrease LDL to 70. If you want regression, decrease LDL to 50. So, personally, it seems quite logical that if you want to minimize MI, you all this should be a population measure. You decrease, keep your LDL to 70 guidelines, less than 100. But the current thinking is if you decrease it to 70, because atherosclerosis stops, as shown by the reversal trial and the other trials. So currently, even the lipid association other things, preferably keep it to 70 if you want to be away from. If 50 is excellent.
Okay, very good. In case the patient doesn't want to take statins, do you have any issues with this patient?
See, statins are most cost effective and most effective agents. If statins cannot be used, you have other drugs like ezetimibe, you have then bempedoic acid. They can be used to achieve the LDL goals. Other agents are, of course, very costly, whether a PCSK9, inclisiran. And the most recent thing is the CRISPR technology. The gene editing, you inject the PCSK9 gene is edited, and for the rest of your life, your LDL drops to 40, 50, or 30. That is the most exciting. The first patient in New Zealand has already undergone successful gene editing, and if that the trial is already ongoing, if that becomes possible, although it's a very costly affair, a single sitting with gene editing will lower LDL to the rest of the life.
Yeah,
With minimal
you
benefit.
you were talking about the LA volume or LA kind of
Yes.
studies in hypertension. How detailed that you would like your echocardiographer report on LA study in a given patient of hypertension, ordinary given patient of
Yeah,
hypertension?
usually we report for the LA size. LA volume can also be measured. People also measure LA strain, but LA strain is not so much validated. Although those who do research work, they often measure LA strain, but LA strain is not yet a universally accepted and a guideline based recommendation. Usually we measure LA volume and the LA size, and these days some people also have left atrial fibrosis, because if you have a left atrial fibrosis you become more prone for AF and even a stroke. And the RFA persons, they want to look at LA fibrosis.
Another point that you were mentioning about the stiffness of the arteries and it kind of driving the cardiovascular events in a given population of hypertension. What is your take on in your clinical practice? Do you measure the arterial stiffness?
It should be measured if you are having a department to measure all these things. Pulse rate velocity is not that difficult, it can be easily measured, the normal being 8 to 12. It should be measured, and if you have a higher pulse rate velocity, calcium channel blockers are the drugs of choice. they have a very smooth lowering of blood pressure, and they also improve the vascular stiffness.
Any other questions from the audience? Because I don't find anything in the box here coming up. Uh, in fact, there is another question from Dr. Reshma here. What would be the recommended dose if we need to start statin for an LDL patient of hypertension with LDL slightly elevated, say more than 100, and non-diabetic?
See, all depends on what is your goal. If you want to decrease cardiovascular event, keep your LDL round about 70. If you want to prevent MI, keep your goals round about 70. If you want to be away from MI, keep your goal at 50.
So,
And the current concept is the cumulative index. All of us develop MI when the cumulative index exceeds 7,000, which is number of years multiplied by the LDL levels. So you will only develop MI when it reaches 70. Suppose you have 100 ml, 100 milligram. You will, right from the early age, it's not that at 50 years you are measuring 100. You will develop MI at the age of 70. 100 into 70 is 7,000. Suppose you have 70 right from early age, you will develop MI at 100 years. And that's why people say you can live up to 100 years with very good control of LDL. And I think some of the great luminaries of cardiology have LDL 30, 40, 50, and they are still alive over 90. So all of us keep LDL much lower, and we take statins, although we don't have any coronary artery disease.
would you
Good,
like to
very good.
advise aspirin to a patient of hypertension?
No,
LS?
unless he is a very high risk primary prevention or he is an LP elevated. Otherwise, not. Primary prevention is not recommended. More harm than the benefit.
How about diabetics and hypertension? Would you like to recommend statins or
How much?
statins for diabetic hypertension?
See, moderate intensity statin is recommended for all diabetic patients. But if he's a high risk, it can be even high intensity statin use. See his risk profile, moderate intensity for all type 2 diabetic patients.
Fair enough. Any other questions in the from the experts on the faculty? Any Dr. Kaur, is he able to start?
No, sir. Still he has not joined. There is a
Okay, fair
connectivity
enough.
issue.
No issue. Now, I just wanted to ask this final question to you, Dr. Manoria. You were saying about the heart rate. How do you reconcile to the office blood pressure or the office measurement of the pulse rate? And how do you decide about the initiating beta blocker therapy for your patient?
No, office is not at all reliable. There's a lot of sympathetic stimulation. It has to be under basal states. So once patient is coming to the hospital, that is not the real heart rate.
Fair enough. Now, how do you consider or what do you think is the basal state when you would like to measure the pulse rate then? What is your take on
Basal best state is just like the sprint trial.
print? I mean, in the sense, I just want to
Very
have it.
difficult.
One important point, Dr. Nagraj Desai and Dr. Manoria, that normally when the blood pressure rises, normally the physiologically heart rate decreases. But whenever the heart rate with the blood pressure is over 80, it's very significant. It must be brought down.
Fair. That's an interesting observation. I'm sure the sympathetic overlay.
Yeah, the brain bridge reflex is there and the heart rate should come down.
Fair enough. Fair enough.
Lower the heart rate, you survive long. People say there's a fixed number of
Sure.
beats to every individual. So whether you finish in 70 years or 80 years, the lower your heart rate, more number of years you will live.
Any
Right,
questions
right,
from Dr.
right.
Sangram himself? He being a professor of medicine, does he have any message for the audience during this meeting, during this lecture, Dr. Sangram?
Yes, sir. Heart rate is one of the important finding nowadays, which is counted. That's why people are monitoring heart rate, ambulatory blood pressure, home blood pressure monitoring. All these concepts have come up in a big way. They are individual subspecialization has come up now. Home blood pressure monitoring,
One
office blood pressure monitoring. Yeah.
One
Yes, sir. Yes,
problem which one problem which many patients bring into us, that whenever we take blood pressure with sphygmomanometer and when we take with a home measurement, the blood pressure always is varying, very reported high or reported very low. How to settle that issue of
Measure blood pressure with automated
electronic
BP
blood pressure
instrument.
measurements and standardization?
Measure
Yes.
with automated BP instrument. Physically, when you measure blood pressure, there's always an error.
Yeah.
Best is automated BP instrument.
That's right. The sphygmomanometer tends to kind of put in the errors.
Absolute.
Automated blood pressure recording is ideal. In fact, I have published myself along with my colleagues from JSS one observational study on the unobserved blood pressure in the office setting. As I'm rather not that busy like Professor Manoria, and I have
Dr.
this.
Nagraj always writes very early. BP variability, I was reading the article very, very early when it was not a concept.
So, in fact, we published that. In fact,
Yeah,
very interesting
I
that
read that.
always the systolic blood pressure and diastolic blood pressure comes down by 20 by 10. In other words, if you depend upon just the office blood pressure taken by us individually, it can be so high that it may be misleading and being accused of physician inertia being avoided, you may end up using more drugs for your patient. In other words, out of your office blood pressure measurement, be it within your clinic premises or maybe in the home area, it is worthwhile to have that kind of data for your patient for the safety of your patient. Now, I am almost coming to the fag end of my, present or rather this particular meeting. Could I have a final comments from Dr. Manoria, please, before I give my final, you know, uh, either words on this particular meeting? Dr. Manoria, please.
I think hypertension is a silent killer, and therefore the best thing is whosoever comes to the hospital, the blood pressure of all attendants should be taken. Whosoever visits the hospital or whosoever visits even in OPD or in the ward, all individuals, the blood pressure should be taken, and that's only way we can diagnose it early, because it is a totally asymptomatic disease and the patient is not going to come. The second important feature is the hypertension is an asymptomatic disease, and it is very difficult to make an asymptomatic individual feel better with treatment. Usually the reverse happens. So that is another problem why compliance with treatment is bad, because we must be very careful in initiating antihypertensive therapy, particularly in the young individual. Suppose you prescribe diuretic, he's in a busy office, he has to go again and again, that creates a lot of problem. So you cannot make an asymptomatic individual feel better. That is again a very problem. Coronary arteries, patient angina relief, he feels happy. Here there's no problem. You make more problem after treatment. And uh, the attempts to improve the control rates must be with the cohesive efforts of all the organizations. You cannot have control rates slashed down with the medical fraternity. Medical fraternity is not powered to slash down to control it, because you can only see the patients which are coming to the hospital. There are large number of patients outside the hospital who are not being tackled, who are not undiagnosed. And if you look at statistics, large number of patients are undiagnosed, large number of patients do not receive treatment, large number of patients received suboptimal treatment, and control rates are very less, 10 to 12%.
Wonderful, sir. In fact, thank you, Dr. Manoria, for this wonderful presentation. He almost presented what is called the 10 commandments of the newer facets of hypertension. Although I would call it as a kind of commandments, mind you, quite a few textbooks of hypertension have already covered in a very elegant manner. And opening statement of Dr. Very well. I can't remember the name of the person at this moment, except to say that the blood pressure measurement is hopelessly done or sloppily done by a physician, and it may be even nurse or any healthcare giver for that matter. Now, we should understand the high blood pressure, and beyond that, we should understand our patient, because just a blood pressure patient may not have just a number which is increased. It may be associated with several comorbid conditions, and the patient's personality itself that you are going to influence upon. And also the family's personalities also will be very important according to my own perception of practice of hypertension since almost about 45 years and plus. Having said that, the selection of the or the non-pharmacological treatment, though it was emphasized upon, it did not receive the attention of the audience. I am sure you appreciate this fact as much. So also the drugs and their selection and the combinations and the duration of action of these drugs and combination therapy and the compliance of this particular patient should be considered as an important aspect of the total management of patients with hypertension. May I say, as Dr. William Osler said nearly 100 years and plus ago, that treat your patient as a whole, not just the number, nor the disease. You treat the patient with the disease rather than you treat the disease in a patient. Thank you so much for this opportunity given to me and also to my esteemed panel here. It is a pity that Dr. Kaul could not join because of his engagement in Paris. And may I request Dr. Biradar for his comments and the final comments, please. Thank you so much.
Nagaraj, I enjoyed your pinpointed questions.
Oh, sorry, I was conducting a viva voce for you. No, no. I
Before that, any comment from Maya, sir?
Thank you. Thank you so much for your patience. And I knew him as a senior resident in cardiology. He was always impatient, and very accurate and very, very kind of obstinate and very, very kind of disciplined a person. He happens to be so even today. Dr. Manoria, thanks for this nice presentation.